This podcast is being recorded on the lands of the Wurundjeri and the Bunurong people of the Kulin Nation. We pay our respect to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders, past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa New Zealand and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we will use the commercial name. Please note that availability can vary between Australia and Aotearoa New Zealand.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest clinical guidelines and research in obstetrics and gynecology through conversation with leading experts. Pelvic pain affects 1 in 5 women in Australia and Aotearoa New Zealand at some point in their life. Pain conditions are broad and there are many pain generators. These can include endometriosis or adenomyosis, pregnancy or postpartum pain, irritable bowel syndrome, bladder pain, and more. Today we're discussing the broad spectrum of approaches to address and manage pelvic pain. My name is Dr Heather Waterfall. I'm a generalist obstetrician and gynaecologist based in South Australia. An important part of my work is as a laparoscopic gynaecologist working with women with pain and endometriosis. Joining me in this discussion is Dr Marilla Druitt. Marilla, could you tell us a bit more about yourself?
Thanks, Heather. So after a lap fellowship at Monash, I became an O&G and I practice in Geelong in public and private in Victoria, in Australia. I'm the current president of Pelvic Pain Victoria, which is a bit of a disclosure, and I do research in mind-body treatments for pelvic pain.
In a previous episode of Talking O&G, Marilla, Prof Cindy Farquhar and myself unpacked the RANZCOG Australian Living Evidence Guideline on endometriosis. Today, Marilla and I wanted to take a deeper dive into some of the other aspects of pelvic pain and approaches to treatments that gynecologists maybe aren't as well versed in. Let's start by looking at some of the first-line treatments for pelvic pain. The standard initial treatment, and that's recommended in the RANZCOG Living Evidence Guideline, is hormonal treatments, and oral contraceptives is top of that list. And there's now a vast range of options when it comes to the tablets that we can recommend or prescribe, with the rising use of some new options like Zoli, Slinda, Vizan, Raico. What's the pros and cons? What are the practical considerations should we keep in mind when we're prescribing these medications?
So in a perfect world, we would know everything about someone so that we could pick the right hormone to begin with. But as you know, we haven't quite got there yet. So we need some pharmacogenomics, research. So at the moment, we've got to work out which type, which dose, the way to get it into someone. Is it going to be in your arm, as an injection, as a tablet, as an intravaginal, as an intrauterine? How long is it going to take to get the effect that you want, particularly for stopping bleeding? It's easier to stop ovulation earlier than stopping bleeding. Do you also need contraception? Do you have any contraindications to estrogen? So there's quite a few variables that we have to work through. If you know that someone has endo and pelvic pain, then on page 70 of this big, beautiful guideline of 262 pages, we have got a great table. And so that might be a good place for some people to start if they're just thinking, oh, my gosh, I don't know where to start. So here we go. We've got things to try first because they've got the most evidence, things to try next because they have less evidence, things to try that you can only use for a short amount of time, and things that you can use for a longer amount of time. I think people should start off with safe, easy, old, cheap thing first, which is usually something like the combined pill. And
for women who've already used the combined pill or can't take estrogen, I've jumped onto the Slinda bandwagon. I prescribe a lot of Slinda. What are your thoughts on using Slinda as both as a contraception and for women who've got pelvic pain associated with their periods?
In Australia, at least, we have a 350 microgram of norethistone, a 30 microgram of levonorgestrel, and we've got the drospirenone pill, which is Slinda. So they are all covered for contraception on the PBS. And then we also have Vizan or Dienogest, which is non-contraceptive, but essentially another progestin to choose from. The Vizan/Dienogest and the Slinda/drospirenone will usually stop people ovulating, but everyone's different, so not everyone does. And so then if you don't like mid-cycle pain or you've got cyclic symptoms, maybe then you want to start with a stop ovulating type pill. The problem with that, obviously, is that some people do like ovulating. That's when they want to have sex in the middle of the month when they're ovulating. And so that trade-off might not be acceptable. So we've got to talk about the pros and cons of that with someone. Then we've got the 30 microgram levonorgestrel and the 350 mics of norethisterone. Those doses do not stop people ovulating, but because you've got progesterone receptors everywhere in your brain, in all of your tissues, maybe actually the pain effect for that individual will be enough on those doses and they can still ovulate. Or you can go up in the dose. So there's a great table in one of the New Zealand documents about 2 levonorgestrel a day often will stop people ovulating, not everyone. But from a norethisterone point of view, you've got to go from 350 mics to 5 milligrams usually to stop ovulating.
That I suppose that is a lot of hormones to think about and a lot to take in. But I like the fact that we can say to women that one pill will not suit everyone, and this is why we have a menu to choose from. And if you don't like the first option, then we'll wash it out and we'll take try a different pill when you're ready and try a different combination, a different estrogen, a different progesterone, and hope that your symptoms are better.
Yep.
Hoping not to swap one problem for a new problem.
So absolutely set your goals before you have the treatment, right? Are you prioritising not bleeding over, not ovulating? Is contraception absolutely the most important thing right now? If you've got terrible pain, maybe you don't want an IUD first. You need to get your pain a bit better first, and then you put in the IUD if you've still got bleeding. I think we need to get better at goal setting with people rather than here you have a hormone, which I don't think anybody does, but often that's what people hear.
Mm-hmm. Yeah, and definitely in my practice I see a lot of women who are really not wanting to have synthetic hormones as part of the way they manage their pain. I then try and steer them towards more of the lower dose options, and hormonal IUD, Mirena, is my go-to. But with insertion of a Mirena comes with it pain as well. How are you managing those women?
Generally with their pain, or the people who don't want hormones?
The people who don't want hormones.
So I think we need to start with a story of the number of periods that people are having these days is evolutionarily unprecedented. So, 500 compared to maybe 150, thanks to the Beverly Strassman anthropological data from Mali. Natural is not necessarily helpful, but anything we give people should make them feel better, not worse. We don't have to swap one bunch of horrible symptoms for another bunch of horrible symptoms. So only they can report what they think that trade-off is. Because there's no point having no periods and much less pain, but now your mood's terrible. That's not acceptable. I think it's important to state at the outset that this is supposed to make you better. And if it doesn't, we need to do the next thing. In terms of natural, sure, hormones aren't natural, but the number of periods we're having at the moment is not natural either.
We've had RANZCOG now available in Australia for, I think, 3 years. And I actually saw one of my ladies who has been on it now for more than 2 years, and she's done her bone mineral density, because we know that the part of the prescribing of RANZCOG in Australia is that we are supposed to do a baseline bone mineral density and annually thereafter. This young lady was debilitated by endometriosis pain. I did a laparoscopy. I excised a fair bit of endometriosis. She didn't tolerate a Mirena. She didn't tolerate the combined oral contraceptive pill. Slinder wasn't enough and she bled through it. And we started her on RANZCOG, and she has found it to be life-changing, but she's been on it 2 years. And her GP's told her she needs to stop it because she's had 2 years worth.
So we don't have data over 2 years unless someone's published it in the last month and I haven't seen it. I'm pretty sure I hopefully would have. So all we can say is, well, hooray for you. We found the thing that makes you happy. And if your bones are good, well, great. But what happens if there are unknown unknowns? What happens if something else happens after the 2 year mark that we can't predict yet? That sort of shared decision-making approach. Luckily, we still have it on the PBS. You don't actually have to go onto a private script after 2 years. Thanks for that hot tip before. That was great. So, I don't know. I'd probably leave her on it. Which is probably what you did.
Yeah, that's what I did. I had a balanced discussion of the nuanced benefits, risks associated with it. And we chatted about, I don't know what the effect on her fertility is going to be when she's been on this medication for more than 2 years. I don't know what the long-term effects are, but I can say that if we stop it, more than likely she's going to be debilitated by pain again. We haven't found anything better. And after that discussion of risk versus benefits, and we looked specifically at the PBS, which said it's not meant to ideally be used for more than 2 years, but as long as her bone mineral density is okay, she's made the decision she's going to continue using it. We discussed the importance of weight-bearing exercise, vitamin D, other things she can do for her bone health, and she's continuing on her other pain strategies as well.
Yeah.
But she's really not needing them as much anymore.
Well, so you're using that, now I'm a bit better as a catalyst for change. Now let's go and fix all of the other things, or make sure all other body systems are optimised, make sure your pelvic floor is fabulous, your bladder and your bowel function is good, your brain is good, your world is good. Use that time to optimise everything else so that if you do need to come off it, maybe everything else is so much better that it's not as impactful as it would have been had you done none of the rest of it.
So that segues into the next thing I wanted to ask you about was physiotherapy. As a disclosure, I own a private practice, and in our practice we are so lucky to have amazing pelvic floor physiotherapists. What can physio bring to the table for these women who've got pain either before or after laparoscopic surgery?
So in the endo guidelines, we finally have enough research evidence to say, yes, physiotherapy is very helpful for pain. And this is something that I think a lot of us knew for a long time, but it hadn't quite made it into the literature yet. A good physio will address the biopsychosocial of pain. They will be pain neuroscience educators. They'll do the top-down of, you can't have pain if you don't have a brain type approach, and teach people stuff, because when you learn about pain, some of your pain gets better. They will also do the bottom-up stuff, which is bladder and bowel function, optimising your pelvic floor, making muscles move. I don't know, often I felt like a bit of a physiotherapy triage service, really, because so many of my patients would get better with that approach.
Pain medication. What are the pain medications you're using in your practice, and what do you think works for women?
I would love anyone who's looking after women with pelvic pain to be confident using amitriptyline. I think it's a great drug. It's been around since the 1940s. And, any drug that's that old, usually we've got a pretty good idea of its safety, which is important. It has a number needed to treat of 2, which means you only have to treat 2 people for one person to benefit. But I don't think anyone's done the study of does it work in pelvic pain. But people with pelvic pain have so many other comorbidities. We do have research saying amitriptyline can be useful for the other comorbidities. And the point there is you can't treat one pain if you don't address all the pains, right? So we've got evidence in migraine, in IBS, in fibromyalgia, in bladder pain syndrome. So if there is any of that going on, I think that's worth considering. I think people need to know up front that, yes, it is an antidepressant, but at antidepressant doses. Otherwise, if someone leaves your rooms and they think, oh my gosh, why have I just been prescribed an antidepressant? This makes no sense. They're not going to take it. So the 150 to 300 milligrams a day dose is the antidepressant dose, and it's probably one of the best antidepressants there still is, but it's not safe enough in overdose to give to people who are really sick. So it doesn't get used much as a first line. Because it's been around for so long, people then worked out that it was good for kids who wet the bed at night. So, 75 milligrams, somewhere around there, might be good for camp for the week. So you just go on it for a week, have a nice camp, go off it. And then the pain dose is maybe somewhere between 2.5 and 25 milligrams. No one, again, has done the trial of how much, or the dose finding trial. So usually I get people to start off with a quarter of a tablet, so that the lowest dose that we can get in Australia, at least, I'm not sure about New Zealand, we can check, is 10 milligrams. So get them to get a tablet cutter, cut it into quarters, make sure it doesn't all scoot off and the dog eats it. And then you start on 2.5 for a night, and it makes people a bit sleepy, which can be really good because if you fix sleep, then often pain gets a bit better anyway. 2.5 for a week. If you have no side effects, which is what I'm after, like I'm not necessarily looking for an effect at that dose, then maybe go up to 5, and then 7.5 and 10. And so I haven't really found in my clinical practice anything north of 25 milligrams is super useful. So I'm happy with that sort of range. And then if that's not working, well, then come off it. It can also be used with an SSRI. So that serotonin syndrome thing, which has been a concern in the past, might be a thing, might not be a thing. It's probably not a thing, but because it's written everywhere, we should tell patients about it. That if you're on something like Zoloft or, fluoxetine, sertraline, and you are on a low dose of amitriptyline, there is this theoretical risk that you'll have way too much serotonin. So there's a good handout on the PPFA website about that one.
That is a good resource to have. So I traditionally would start my women on 5 milligrams and tell them to take it around dinner time or just after dinner. But I like the thought of 2.5 milligrams, especially for those women who are super sensitive to any medications and really are going to be put off by bad side effects.
You don't want to waste it.
Yeah, and I don't want them to take it a couple of times and say it doesn't work. But if I warn them that we're starting them on a really low dose so that we can get them used to the medication, and I tell them don't expect to have much benefit in the first month. Push through it, keep taking it, as long as you don't have any bad side effects, and hope that it does give you some benefit in your pain and definitely in your sleep.
Yes, and then use it as a catalyst for change again. So
Yes.
you're going to fix your sleep. So you're going to go on this tablet, and then you need your quantity, quality and routine. So start getting up at the same time every day. And so then maybe you're using the medicine to change your behaviour. And then if your behaviour is the thing that endures as the treatment, maybe then you don't need the medicine anymore.
I like that. I also really like amitriptyline for women who've got painful bladder and for women who have significant nocturia and irritability with their bladder or pain with a full bladder. If you can get them onto a therapeutic dose of amitriptyline, you can then retrain their bladder because they're not getting up 3 times in the night to void. And so instead they wake up, but they've got a full bladder and they can gradually then distend their bladder further and retrain it. And again, it's that catalyst of change that the medication will give us to allow us to do some better bladder training for women who just can't because of their painful bladder with filling.
Yep.
What other pain meds do you use?
Sometimes duloxetine. So if they're not on an SSRI or SNRI and they have anxiety and they are thinking about using a medication for anxiety, it's a bit of a 2-for-1. So again, no evidence in pelvic pain, but has evidence in other pain conditions like fibromyalgia. Again, if you can get a capsule version of it, start off with half the capsule, tip out half of it. So you're starting at a low dose, and after a couple of weeks, you can go up to from 15 milligrams to 30 milligrams. They're really safe medicines. I think they're perfectly within our scope of practice, like any drug can be if you learn it well enough. And again, use it as a catalyst for change. So what are you going to do now that you're on this medicine? You've got a bit of headspace. Are you going to do good psychology treatment, which has good evidence for pain and also pain associated with endo? Are you going to, address your social determinants? Like if you're having, horrible panic attacks and anxiety and you can't leave the house, well, then that helps pain persist. So what are we going to use it to change? And then usually that's a GP-led thing.
People have said before, I don't prescribe pain medications because I don't feel that's within my scope as a gynaecologist. But what you're saying is gynaecologists should definitely feel comfortable prescribing definitely amitriptyline, definitely duloxetine. What about Lyrica, pregabalin, gabapentin?
So if we said that's not my scope of practice, we'd still be practicing the way that we were when we finished medicine. We've got to continually update our practice and make sure that we're providing the care that our patients need. Otherwise, we'd still be leeching people. And so, just because you did something 10 years ago doesn't mean we can't change and do something new now. Do something that you have read about and thought about and trained with and talked to people about. Gabapentin, Lyrica, which is pregabalin, gabapentin, Andrew Horn and his colleagues in Edinburgh did a study, a few years ago, published an RCT to look to see if gabapentin made any difference in pelvic pain, and it didn't. So I would say don't use gabapentin. It has evidence for not working. Does it work for some people? Probably, but we should offer people good evidence-based care that's effective and cheaper and more durable first, and then do other things later.
Another potential contributor to pelvic pain is painful bladder syndrome, either with or without interstitial cystitis on cystoscopy. What are the options for women who have a predominant bladder component to their pain?
Again, they've got lots of options. So we've made sure that they don't have UTIs, that they don't have a bladder cancer, that nothing else is going on. I think there's a little bit of evidence for food working out if particular ingredients in their diet are associated with a flare. And so there's that ICN food app, and everyone's different. Probably it's got something to do with your microbiome. So everyone has to eat food. You may as well fiddle around with your food and make sure that you maintain diversity, but work out if there are any culprits. Caffeine is a funny one. Sometimes we use caffeine to treat pain. Sometimes it makes things worse. You've got to do the experiment for yourself. Things with numbers in them, a whole bunch of stuff in our food system, chemicals that were never actually trialled on humans.
You're talking artificial sweeteners, preservatives.
Anything that's a number.
Processed.
Don't eat numbers, eat food. Physiotherapy. All roads lead to physiotherapy, and people with painful bladder syndrome often have a very sore pelvic floor. Whether or not it's tight remains to be proven on a trial that's happening at the moment in Melbourne. But physio has great evidence for treating painful bladder syndrome. And again, it's getting a pelvic floor to move, to check how someone's emptying. If everyone's renovating their house, you should get a squat toilet because nothing about Western toilets is any good for your pelvic floor. So food, caffeine, don't eat numbers, physiotherapy, and then things like amitriptyline.
We've talked a bit about laparoscopy, and We know that laparoscopy is a major component of the work we do as gynecologists. What work can we do around the time of laparoscopy to ensure that women don't have a worsening of their pain in that perioperative setting?
We've got lots of things, and we could label it as prehab. So get your gut under control, get your pelvic floor moving, do lots of exercise, because exercise is good for all pains, but also period pain. We've got a Cochrane review on that. Make sure your sleep hygiene is fabulous. Get up the same time every day. We respond really well to a routine, particularly for our cortisol and our melatonin. Physiotherapy, pain psychology. The less anxiety people have before they have an operation, the less pain they have afterwards. And there are lots of things we can do to address that, including a recent fabulous trial saying you can use food to treat anxiety with the Deakin Food and Mood Centre in Geelong. I like the idea that in a peri-op setting, things that a patient can choose and be in control of also is really good for your brain and maybe good for pain, although we don't have, fantastic evidence for pelvic pain or pelvic pain operations per se for this. So people who listen to music that makes them feel happy just before they go to sleep are less likely to need more opiates when they wake up in recovery, and music is free. For neurodiverse people or anyone really, if they're feeling really uncomfortable in that theatre setting where everything sounds funny and smells funny and is too overwhelming, having an eye mask, having some earphones or, headphones, having something to smell that is comfortable, comforting, not hospital clinical smell, or something that they can hold, all might add to that experience of decreasing anxiety and improving post-op recovery.
You talked about bowels there. I definitely think managing constipation, irritable bowel syndrome is really important, especially in the weeks leading up to laparoscopy. I personally don't bowel prep my patients unless I think there's going to be bowel involvement. I think the evidence is there now that we don't use bowel preparation. It just causes dehydration and poorer recovery.
Yep, we've got a nice RCT from Sydney. Yep, don't do it.
Don't do it. I think that covers most of the laparoscopy prehab. I like the idea of music. I think that it helps to empower women that when they walk in the door of theatre that they are in control of at least one part of their experience.
It's also quite interesting seeing what people want to listen to. I quite like that.
Marilla, we've talked about things to avoid, artificial sweeteners, things with numbers, maybe caffeine, maybe not. What are the things you recommend for women with pelvic pain?
If you're talking about supplements, so there's a very lovely table on page 78, 88, something like that, and it goes through all of the supplements that have been shown to reduce pain associated with endo. So we have fish oil, and that's really DHA. I would submit that there are not enough fish in the sea, so probably just have an algae tablet because that's where the fish get it from. So that has some evidence. PEA, which is a food supplement that you can get from whole food stores, that sort of idea. It can be a bit tricky to find, but that has some evidence. Vitamin D has some evidence. We know that zinc sulfate has now made it to sort of systematic review, meta-analysis stage of after a good few studies saying zinc sulfate treats period pain. And these people may or may not have had endometriosis, but that's, safe and cheap and easy, and we've got 3 trials. So hopefully that will make it into a dysmenorrhea guideline at some stage, of which no college or authority has in the world, I don't think. So we need a dysmenorrhea guideline. Other things that are not supplements are things like acupuncture and TENS machines. They have evidence in pain associated with endo, and that is something absolutely that people can try. If people do acupuncture in Australia, it's Medicare rebatable too.
From a dietary perspective, you said low FODMAP, and what about fibre?
So is your question, can fibre treat pelvic pain? I don't know if anyone has specifically researched that, but Australians are fibre deficient. We're supposed to be having heaps more than we do. Maybe I think the average is 8 grams a day and we're aiming for 30. What happens in your gut changes everything. You need to feed your good gut bugs with your prebiotics, i.e. all of that plant diversity. You need good bugs every day probably, and the stuff that they make also might be impacting on things. And so fibre is part of that. We know that you can use it to treat irritable bowel syndrome, but depending on what type of IBS you've got, you might need to go slowly. We think the more diversity in your food, the more diversity in your gut, and then that again can change your brain, which is where all of that sort of nutritional psychiatry comes from. Bugs don't like change very quickly, like nobody likes change very quickly. And so if you're going to start to do heaps of psyllium, you can't just get stuck into, truckloads of Metamucil. You've got to go slowly and get them used to it. along with heaps of water.
Take it slowly, eat a rainbow,
Yep.
and I suppose seek the help of a dietitian if you're not sure.
Tanya, I was wondering, have you ever been to the Swan Valley?
Never, no, but it's on my agenda.
It is a stunning part of my home state, and I'm very excited to hear that RANZCOG's 2026 Regional Symposium is being held there at the Vines Resort. It's 21st to 23rd of August.
That's a fantastic location for a conference, great food, and from what I've heard, beautiful scenery.
Absolutely, and this is going to be a brilliant opportunity to connect with other obs and gynae professionals. Be collaborating on the issues that matter most to obs and gynaes and GPs working in rural, regional and remote settings.
And the pre-meeting workshops will be a great opportunity to learn more from other experts in the field. Delegates can even submit their abstracts for presentation, and awards will be handed out during the event.
Early bird prices close at the end of June, so don't forget to get in soon, and I can't wait to see you there.
We're talking a lot about perimenopause at the moment. Do you think the management of pain changes as women hit the perimenopause?
Okay, Heather, here is time for my current take on what's going on with perimenopause. So up until everyone got really excited about LARCs, so Mirenas and Implanons, lots of people were on the pill, right? Particularly in their 40s. So they had this sort of ready-made HRT going on, and that was quite good, but not so great for the DVT risk or, you know, a few other things, particularly with a population whose comorbidities are changing. And so then lots of people swapped over to a LARC, which are very fabulous and heaps better for not getting pregnant with, but no estrogen. Now, I think we're seeing partly what happens when you don't give people estrogen in their 40s. The issue with, you know, perimenopause symptoms is it's a bit like, well, they're very non-specific. They could be due to heaps of things. And the only way that you know is this is a perimenopause symptom is if you have some estrogen and then it goes away. So now I've forgotten what your original question was.
Do you change the way you manage pain as women hit perimenopause?
Not really.
Not really. I suppose
you still have to try all the things.
You do, don't you? Yeah. I think there are a larger proportion of our women who are on LARCs.
Yep.
And if I've got a woman who has a predominant musculoskeletal component to their pain, I'll definitely add on estrogen for those women just in case. And I will get them to do the green climacteric scale, look to see what their perimenopause symptom profile looks like.
Yep.
And then I will give them a 3-month trial of estrogen, especially if they're on a LARC.
It was.
And if they then redo their green climacteric scale and their symptoms are improved, then I'll say, okay, maybe there is an estrogen deficiency component to your pain, in particular that's worsening a musculoskeletal component to your pain. And then I'll use that then to get them into physio to try and also use movement as medicine to try and improve their pain. Otherwise, I think as long as we're aware that as women hit perimenopause, their comorbidities are potentially changing. As you said, they potentially shouldn't be on a oral estrogen anymore, and just recognising that topical estrogen is still safe and brilliant option for women in the perimenopause. And also that if a woman is really well on the combined oral contraceptive pill, there's no reason she has to stop her oral estrogen in her 40s if she's been well on it. As long as she hasn't developed a new comorbidity, she's not a smoker, she's not hit BMI 35 or 40, I just continue them on what's working.
Yeah, I think a lot of harm is done that we say you've got to this age, you must stop this treatment. And then a few years down the track, they've got all the symptoms. And then we think, oh, that's a bit of a pity, maybe we should have stayed on that. But mostly it's done in good faith because oral estrogen does have risks, and the older you are, they slightly increase. So maybe you don't want that if that's not your safest option. So what we do need in Australia is the contraceptive patch. That would be good. Lots of other places have got one. We need it.
Another vital aspect of multidisciplinary care for pelvic pain is psychology. What role does pain psychology play, and how can clinicians learn more about incorporating pain psychology into their practice?
So I love this question, and I think it's really important to say from the outset, particularly when you're talking to your patient, that we've got to get the concept clear in the beginning, because I really don't want someone leaving my room thinking that I've told her that she's a hysterical woman, right? So what we know is that pain makes mental illness worse. Mental illness makes pain worse. There's a bidirectional relationship there. But people might not be ready to treat mental illness, or they might not be ready to treat pain, or maybe they want to do both at the same time. Interestingly, even if someone doesn't have a mental illness, we have treatments from psychologists just for pain. So everyone should know about those complex interplays, and that we've got treatments for people who don't have mental illnesses. Some people love psychology therapies, and if that's what sounds good to you, well, then it's probably more likely to work than if we boss people into stuff that they don't want. It's really helpful for the group who can't be on hormones because they're trying to get pregnant or they don't want to be on hormones or for whatever reason. It's just lovely having another option. There are massive psychological determinants of chronic disease and heaps in the emerging literature about ways that we can use pain psychology to treat pain. Heaps more than in the current pelvic pain space at the moment, but that's coming. We have all sorts of trials on cognitive behavioural therapy, on hypnosis, on mindfulness, on meditation, on, using EMDR even, which is a trauma therapy. So it's an exciting space and people should know. Like, nobody should lose hope that they're not getting better if they don't know about all of the things.
And so I suppose you're really emphasising that pain psychology isn't just for people who've got a diagnosed mental health condition. Pain psychology is an option for anyone who has pain.
Yeah.
And that's the way I think we need to sell it to women. I don't think that you've got something wrong with your brain in terms of I'm not saying your pain is made up, it's not real because I'm sending you to a pain psychologist. I'm 100% acknowledging your pain is real, but here's one of the psychological treatments. Here's one of the psychology treatments that might make your pain better or more easily manageable.
Yep.
RANZCOG has a special interest module and it is about the neuroscience of pelvic pain. What can you tell me about it?
This is my baby. It took me 3 council terms to make happen. It is an ATM, so an advanced training module. It is part-time over 6 months or even more part-time over 12 months, which might work a bit better for level 5s and 6s. And the concept is that you use a lens to look slightly differently at the things that you're doing in your hospital. You might be in a pelvic pain clinic in your hospital, or you might just be in a gynae clinic, but you're going to start using some questionnaires and start having a chat to some pain physicians about your patients. It is about multidisciplinary care, so learning from physios, learning from a psychologist if you have them in your hospital, going to meetings, learning from all of those clinicians, talking about tricky patients, working out who's got the best, most evidence-based care to offer them. There are heaps of resources. It is very ambitious, but, go big or go home.
What about when a patient presents to the emergency department with an acute pain crisis? I'm thinking about our registrars who are working the floors at 2 a.m. and they take the phone call from the emergency department that a woman has come in with a pain crisis. What advice have we got for that registrar and for those women who come in to the emergency department?
So obviously, good emergency care, they will have already probably had an ectopic excluded, a torted ovary excluded, some awful UTI, appendicitis. So we've done tests to know that we're not missing a surgical emergency usually. And then, so you're talking about a situation where we haven't really found a cause. So is the cause that they've ovulated and they're in second phase of their cycle, so they're in weeks 3 and 4. So you could do a progesterone level if they're amenorrheic with a Mirena and they don't actually know where they are. Mostly we don't have any treatments. And so I think we should be honest and say we don't actually have any good medications short of anaesthetising you to sleep that we know can help in this situation. So the Queensland Pelvic Pain Guideline is pretty good. So that's a good place to start, knowing that we don't really have evidence for those recommendations. But a framework is a fantastic place to start.
What are your top recommendations for patients who have limited resources or access to services, gynae, physio, psychology, those who are living in rural or remote communities, or those who, for socioeconomic reasons, don't have the ability to access those multi-D services?
Most places will have a GP. All good treatment starts with a GP, and there are heaps of resources for GPs to learn if they don't feel confident, because we expect them to know absolutely everything, including heaps of stuff on the RANZCOG website. I think nutting out how much of your suffering is uterus, ovaries, muscles, bladder, bowel, brain, world, and then coming up with a plan for things across all of them. Everyone needs to eat food. You can eat food that is low FODMAP because there's some evidence that treats pain associated with endo. We know that food treats mood. We have food trials saying you can use it to treat depression and anxiety. And if you happen to have those comorbidities, then maybe better mental health will result in better pain. Everyone can move, even if that's just doing the stretches from the PPFA website when you're on your bed, or you're going to work out how much exercise you need to do on a daily basis. So AM works better than PM. Out in nature is much better for your immune system than home on a treadmill. But if you don't feel safe, well, then maybe you have to be at home. So doing something is better than nothing, and you've got to work out the dose and the frequency. Sunshine, so light is very important for mood. I'm not so sure about light and pain trials, but if you get up at the same time every day, you're less likely to have pain in the future. So a sleep problem now predicts pain in the future. So you need the quantity, you need the quality, and you need the routine. So half-hour sleep in's about all you get. Then we've got things about physiotherapy on lots of websites, including PPFA. We have free pain resources in lots of different places, including endometriosis foundations, Jean Hales, RANZCOG. When people learn about pain, some of their pain gets better, and plenty of these books are at the library. Learning is good. People always want to know, well, how do I know what is the right thing to read, and how can I trust the source? That's really tricky. I don't think it's outrageous to suggest that people have a look actually at the guideline, because a lot of these women are very health literate and are keen to know where the evidence comes from. So everyone's in search of the truth, and the way that we look for the truth is we do a study. So I don't know, I'm not really suggesting that every woman in Australia reads our 262 pages, but it's not a bad start, and we've got patient resources on our website.
I think the other thing that I really encourage my women to do is have a look and see what research is going on and whether they can enrol in a study. Yep. The Endozone website has a list of current studies that are in progress. Image Endo is happening in Adelaide, and some of my women have been a part of that study. It's a way to get some endometriosis or pain resources, and by being enrolled in a study, I think you get education, you get lots of different benefits, even if you're not in the active arm of a study.
We've got one going on at Deakin at the moment, which is a module system. So you can choose your, diet thing, or your mindfulness, or your hypnosis, or your food, or there's plenty of studies out there. Although some people then have study fatigue and they're sick of it. So it's all about having options.
Giving women options, giving women choices, empowering them, and rolling with them and seeing if there's anything developing, and keeping our eyes out for new research and things that we can give to help target pain.
Yeah. Well, so I think that's our job, right? Like if someone presents to us with a problem that is probably something to do with gynecology, if we get to the scope of, the limit of our scope, it's way more satisfying to learn about the next thing and try the next thing than say, I'm done now, let's book you into a pain clinic that might take 3 years. It's good. When these people get better, it is really satisfying.
Marilla, to wrap up, what are our top recommendations for clinicians who are working with patients with pelvic pain?
Complex problems need complex solutions. If somebody had the discussion at the beginning that we were going to need a lot of things and to cover the bases to recover, I think people would recover faster. So a biopsychosocial approach to pain will get people better than an exclusive biomedical approach. Provide hope. I love looking after people with pelvic pain because so many of them get better, and it is very satisfying. So know that often people really do get better. And then amitriptyline is a really great drug.
That is definitely my takeaway. Amitriptyline, and started in low doses. When women first start talking about pain, it might be a more simple pain where that pain is coming because of endometriosis or because of irritable bowel syndrome. But once you've had pain for days, weeks, months, years, all the other organs around that get involved, and then it becomes a complicated pain. And we need to address all of those aspects of that complicated pain, all aspects of the pelvis, before we've got a hope of improving pain for women.
Agree.
You can find a list of resources discussed in today's episodes in the show notes. If you enjoyed this episode, please rate, review, and subscribe, and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more essential conversations on Talking O&G.